Okay, today we are talking about asepsis and medical imaging. Asepsis is basically just keeping clean, keeping everything sterile for surgery, and keeping everything clean for just regular procedures. Aseptic procedures include biopsies where we're taking samples and sending it to the lab. Angiographic procedures where we're doing like portacasts, where we're introducing A lines or central lines where the nurse puts line placements in. So they're using it for NG tubes, OG tubes, ETT tubes. NG tubes is through the nose, tube is through the mouth, ETT is through the trachea. HSGs, hysterosalpinograms, that is to evaluate the uterus and the fallopian tubes. And then we have arthrograms. Arthrograms are to check for joints. Sources of infection include skin. That's why we're always washing our hands. Our hair, that's why when you go to surgery or work in a kitchen, you wear a hair bonnet. Nasal pharynx, that's why we wear a mask. Fomites, objects, materials, so making sure that we're using sterile gloves. We're using things from sterile processing in surgery. Anything in the air. So that's why there is like reverse flow air conditioning systems in hospitals, human air cross contamination. Surgical asepsis would have to be protecting everything from infection during surgery procedures. Medical asepsis is what we do on a regular basis for the removal or destruction of infected material. So every single PowerPoint, we're going to try to introduce some of the information that we're going to go over next semester. We're going to talk about one of the more severe radiation syndromes, and this is called the cerebrovascular one. Cerebrovascular syndrome. This syndrome deals with the central nervous system and cardiovascular system. A dose of 50 gray tissue or more will cause a reaction. Death will occur within a few hours or 2 to 3 days after exposure. So this is again the most extreme side effect from radiation exposure. It causes injuries to blood vessels and permits fluid to leak into the brain. Can cause intracranial pressure, coma, and death. The surgical team consists of the surgeon, assisting surgeon or physician assistant, the anesthesiologist or the nurse anesthesiologist. The OR nurse is a circulating nurse, so there's two nurses in the room, usually one that is by the table assisting the surgeon with sterile equipment like forceps. And then we have the circulating nurse who sits there at the keyboard computer, doesn't have gloves on. She's just recording that the case has started, who's in the room. If the surgical nurse needs any kind of supplies like normal saline or anything, then the circulating nurse can circulate around the room and grab whatever items that are needed in the case. Then there's us. And then the support OR staff would be the people who are monitoring the electrical signals or helping with the circulation of blood or other things, or like the vendors. Okay, important slide, sterile field, microorganism free area that can receive sterile supplies, established using a sterile drape. Contains no viable microorganisms, must be clean and dry materials only. The materials cannot be expired or opened. Sterile corridor is the area between the patient drape and instrument table. Establishing a sterile field drape. Establish a sterile field. Holding the drape with one hand by the corner, fold back the top and lay the drape on a clean, dry surface with the bottom furthest away from you. Dropping sterile contents onto a sterile field. Drop the contents onto the sterile field about 6 inches above the field at a slight angle. This technique ensures that the wrapping does not touch the sterile field. Do not reach across a sterile field. Pour sterile fluids into a sterile basin, 6 inches and above. Containers considered sterile. Verify contents and expiration date. Pour exact amount of solution. Avoid splashing contents onto sterile field. Pour at edge of sterile field about 6 inches above container. Surgical scrubbing. remove, reduce microorganisms. Sterile scrubbing with an antimicrobial agent. Surgical scrubbing involves numbered strokes, timed method. Putting on a sterile gown. Self-gowning. Grasp the gown firmly and bring it away from the table. It has been folded so the outside faces away. Holding the gown at the shoulders, allow it to unfold gently. Do not shake the gown. Place hands inside the armholes and guide each arm through the sleeves by raising and spreading the arms. Do not allow hands to slide outside cuff or the gown. The circulator assists by pulling the gown over the shoulders and tying it in the back. Sterile gloving. This is called the open technique. This is the one that you'll do mostly when you're setting up arthrogram trays. Pick up the glove by its inside cuff with one hand. Do not touch the glove wrapper with the bare hand. Slide the glove on the opposite hand, leave the cuff down. Using the partially gloved hand, slide the fingers into the outer slide of the opposite glove cuff. Slide the hands into the glove and unroll the cuff. Gloving over a sterile gown. This is called the close technique. Lay the glove palm down with the cuff of the gown, the fingers of the glove facing toward you. Working through the gown sleeve, grasp the cuff of the glove. Bring it over the open cuff of the sleeve. Unroll the glove cuff so that it covers the sleeve cuff. Gowning another person. Grasp the gown so the outside faces towards you. Hold the gown at the shoulders. Cuff your hands under the gown's shoulders. The person steps forward and places his or her arms in the sleeves. Slide the gown up to the middle arms. The circulator assists in pulling the gown up and tying it. Gently pull the cuffs back over the person's hands. Be careful that your gloved hands do not touch his or her bare hands. Two-person gloving. Pick up the left glove and place the palm away from you. Slide the fingers under the glove cuff and spread them so that a wide opening is created. Keep thumbs under the cuff. The person thrusts his or her hands into the glove. Do not release the glove yet. Gently release the cuff while unrolling it over the wrist. Proceed with the right glove using the same technique. Removing sterile gloves. Removing contaminated gloves aseptically by grasping the edge of the glove. Unroll the glove over the hand. Discard the glove. With the bare hand, grasp the opposite glove cuff on its inside surface. Remove the glove by inverting it over the hand. Chest tubes, also known as thoracostomy tubes, drain the inner pleural space and mediastinum of fluid or air. It creates a negative pressure. It's used for atelectasis or collapse of a lung. It helps reinflate it. Pneumothorax is air outside of the lung in the body tissue. Hemothorax is blood in the pleura. Pleural effusion is fluid in pleura. Empyema is collection of pus. And chest tubes are used for open heart surgery. Common insertion sites include thoracostomy, vary with interpleural substances to be removed, usually inserted into 5th or 6th intercostal space, usually in the mid-axillary line area, so right around here. Tech responsibilities include we take x-rays to perform chest tube position and chest status. We got to be careful not to catch tubing on the x-ray equipment. We don't want to pull the tube out. Exterior assembly of the chest tubes must always remain lower than the patient's chest. We don't want the fluids to drain back into the chest. We want it to drain away from it. This is an example of a chest drainage system right over here. So this is usually found on the floor of a patient's room. So make sure you don't hit it with the portable machine. Foley catheters, same deal, various procedures, various purposes, bladder emptying, introduce drugs into bladder, measured of urine output. So we put this in the urethra. This balloon inflates to hold it in place, acts as an anchor. If the urine collection bag is emptied, output must be measured and recorded. Indwelling catheter placement, tube attached to drainage bag. So this tube here attached to this drainage bag. Drainage bag is lower than the patient to prevent retrograde flow into the bladder. So we don't want to put this up above like an IV because we don't want it to flow in, we want it to flow out. Watch drainage bag and tubing when moving or transporting patients. Removing a urinary catheter, performed for VCUGs Wash hands and explain procedures. Put on gloves. Put basin under catheter valve and allow water to drain into the basin. Once flow has ceased, pull gently. Stop if resistance is noted and inform the nurse. Maybe you forgot to deflate the balloon. Once removed, wrap in towels, cover patient, and discard catheter. Venous and arterial lines, A lines. Sterile technique is required for lines or catheters into veins or arteries. Requires imaging to confirm placement and functionality. Is the line too short? Is it in the right area? Must be aware of lines and their equipment and positioning. Pacemakers. Pacemakers are inserted under the skin to regulate heart rate. Pacemakers are 1 inch wide, 1 inch thick, weigh about 1 ounce. Under fluoro, the physician will place the guide wire and pacemaker. So pacemaker here, guide wire is here. Most pacemakers are MRI compatible. Usually they come with like a little MRI compatible card that they must show an MRI tech. Portable and surgical x-ray. Be aware of the sterile corridor. Again, that's the area between the table and the patient. Fluoro requires DR, IR, and to be draped, and the patient to be draped as well. IR, DR detectors are gaining popularity in OR, especially for like hip replacements. Drape of C-arm and patient by a surgical team. C-arm drapes usually a bonnet or a curtain, or not so popular item, a third cloth. Mobile radiography performed at the patient's bedside requires a mobile x-ray unit. So we come to the patient doesn't come to us. Usually it's a C-arm for a mobile fluoroscopy. We bring the C-arm into all the different OR rooms. Here is the image intensifier on one side and the tube on this side of the patient. So of course this isn't a sterile procedure, but just giving you an example. But in the surgery case, you can see that they do have a hair bonnet on to help with the asepsis. C-arms in surgery. Performed fluoro procedures. Working space is really tight as pictured here. This is a pretty typical OR room. We maintain a sterile field again with the bonnet, curtain, or possibly a third cloth. So a bonnet would go on this part here, kind of like a hairnet, but for the image intensifier. A curtain would be a whole big piece of plastic that covers the entire thing like a sleeve. And then we can put our hands inside this area, inside of the curtain to move this tube into from AP and lateral positions. Again, image intensifier is here. Here is the tube down over here. The tube is down below the patient to reduce scatter. Patients requiring portables are usually critical patients in the intensive care unit, in the ER, and surgery, and PACU. So medical asepsis, surgical asepsis, and PACU is medical asepsis. Neonatal intensive care unit, NICU, are babies who are premature, low birth weight, or have acute health issues. Portables performed while the infant is in an incubator. Usually the incubator has like a heating area, kind of like the same thing they do with like little baby chickens. They're necessary to keep baby warm. Shielding is essential. Gown and gloves are required. Okay guys, last slide, conclusion. Aseptic techniques reduce harmful microorganisms. Surgical and medical asepsis required for a variety of situations. Sterile techniques require proper gowning, gloving, and masking. All right, thank you.